Artificial intelligence is increasingly functioning as a stopgap measure in areas and situations where traditional healthcare access is severely limited. This is happening in predictable patterns: rural areas with severe provider shortages, urban medical deserts where clinics have closed, and the vast temporal gap when medical offices are closed, but health concerns don't stop. Let's be clear about what AI can and cannot do in these contexts. AI can provide basic health information, help people understand their symptoms, suggest whether something might be urgent or can wait, and offer general wellness guidance. What AI absolutely cannot do is perform physical examinations, run diagnostic tests, prescribe medications appropriately, or provide the clinical judgment that comes from years of medical training and experience. In rural areas with physician shortages, AI is filling a desperate need. When the nearest doctor is 50 miles away and booked months out, when the local hospital closed years ago due to financial pressures, people are left with extremely limited options. For basic health questions and minor symptom guidance, AI provides information that might otherwise be completely inaccessible. Someone in rural Montana with a rash can get basic information about whether it might be allergic, infectious, or something requiring urgent care. This isn't ideal, but it's better than having no information at all when medical care is hours away. However, we need to confront the serious reliability limits. AI's inability to perform examinations is a fundamental constraint. A doctor can listen to your lungs, palpate your abdomen, check your reflexes, look in your throat. AI cannot. This means AI is always working with incomplete information and must make probabilistic guesses based on symptom descriptions that may be inaccurate or incomplete. AI can triage, helping determine whether something needs immediate attention, can wait for a regular appointment, or can be managed at home. But this triage is inherently less reliable than human clinical triage because it lacks physical assessment data. Infrastructure needs create another layer of inequality. AI health assistance requires reliable internet connectivity and devices capable of running the applications. In many rural areas and underserved urban neighborhoods, broadband access is limited or non-existent. Device ownership is not universal, and many people rely on older smartphones or shared family devices. This means the very populations who most need alternative healthcare access because they lack traditional options may also lack access to AI tools. We're potentially magnifying health disparities rather than reducing them. Affluent urban residents get both in-person care and AI assistance, while poor rural residents get neither. The risk of substitution is real and disturbing. When AI becomes available in underserved areas, there's political temptation to treat this as solving the access problem rather than as a temporary inadequate band-aid. Instead of investing in rural hospital funding, physician recruitment, and telehealth infrastructure with real doctors, policymakers might point to AI availability as evidence that rural residents have healthcare access. This would be a catastrophic mistake. AI should be a bridge to actual care, not a permanent replacement for it. What might responsible implementation look like? Pilot programs that pair AI with community health workers show promise. A trained community health worker can perform basic vital signs and physical assessments, then use AI to help interpret findings and determine next steps. This combines AI's information processing with human clinical observation. The community health worker provides the physical examination and judgment, while AI provides medical knowledge and decision support. This hybrid model addresses some of AI's fundamental limitations while extending the reach of limited healthcare personnel. But even this requires investment, training community health workers, providing them with basic diagnostic tools, creating supervision and referral networks. It's not cheap, and it's not as simple as just giving people AI access and declaring victory.